of the month. And this is Dr. Anupama Gotimukula. I'm president of AAPI. All of you know me very well. And so this is successfully, we are on the almost like the nine months of CME. We did every month almost, and we have done some out of country trips, and then we had CMEs. So we had a goal of giving 50 credits of CME for our members. And this is a sincere contribution from AAPI organization to its membership. And I welcome today's speakers, and Dr. Weiner and Dr. Sogoyan, and if I spelled your name correctly. And thank you so much for being our CME speakers today. And we very much look forward for this excellent topic. We all go through this polypharmacy, our patients, and it causes, it's a syndrome actually, I would say, you know, all these patients on multiple medications having side effects, which one causes which side effect, we don't know. So there's a lot to learn about this polypharmacy. And so our physicians try to reduce the number of medications our patients use. They try their best, but some of them are on 20, 30 medications. I'm a pediatric anesthesiologist, and I see some kids who have seizures and multiple developmental disorders. They are on like 3 pages of medications. So when I go through the pre-op checkups, I see like 2 or 3 pages of medications they are on. I wonder what exactly are these medications? Are they helping or are they causing more damage? But we are so much looking forward for your talks, and I will give it to our CME chair, Dr. Amit Chakravarti, and also my moderator, Dr. Sagar Galvankar. And I have the next incoming president, Dr. Ravi Kohli. He's also with us in the panel. Thank you so much, and let's get started.
Right, thank you, Anupama. That was a very, this is a great polypharmacy is a very, very great talk, which is applicable to every specialty. As you know, this year as a CME chair, with the help of Anupama, we have tried to put topics which are of interest to all specialties, not necessarily specialty specific. And I already really appreciate Sagar for being such a great support and getting all these wonderful speakers for us. And I'll introduce Sagar in a little while. He's the CME co-chair. But let me first introduce the first speaker. Her name is Dr. Sari Sagoyan. She's a graduate of McGill University School of Medicine and completed her residency emergency medicine at Kings County Hospital, SUNY downstate in Brooklyn, New York, followed by a fellowship in medical toxicology at the NYC Poison Control Center and University School of New York University School of Medicine. She has been faculty in the Department of Emergency Medicine since 2009. She has served as clinical coordinator and lead clinician for the Corle-Bu Teaching Hospital, Department of Emergency Medicine in Accra, Ghana, which she helped found from its inception in 2012 to 2019. She spent the pandemic back in New York at work in Bellevue Hospital Medical Center and NYC Poison Control Center. She's serving as special advisor to the NYU-led AMPAC Ghana Academic Partnership with University for Developmental Studies and Female Teaching Hospital in Northern Ghana. With Sage, she has been, Sage that is her co-speaker. With Sage, she has been longtime member of Indus EM and VACEM, emerging with annual conference and CPC competition in particular as a highlight of the year. So she's a very well-spoken, well-renowned, and well-respected person in the field of emergency medicine and has special interest in polypharmacy. We cannot wait to hear from her. And after she finishes, I would encourage you to put your questions in the chat box. And after she finishes, I will introduce Dr. Galvankar for moderating the session and doing the discussion. So over to you, Sari.
Okay, great. Thank you so much for that introduction. have hopefully unmuted myself. If I have not, please put it in the chat, and I'm going to share my screen now. Let's see. All right, give me a thumbs up if you can see my slides. Okay, great. Thanks so much. I'm Sari, and I'm going to talk to you a little bit about some polypharmacy challenges today from the perspective of a medical toxicologist. And I have no competing interests to declare. And my goal, I think the goal overall that Sage and I both wanted to address is really to present some examples of acute poisoning from drug interactions that we've seen in our practice, either as emergency physicians or through our work at the New York City Poison Control Center, to serve as kind of illustrative examples and warnings about some of the things that can happen when people take different medications together. And they interact in nefarious ways. And in the course of doing that, we'll talk a little bit about the general mechanisms by which these things happen. And pose risks. And then I think at the end, I'll just make a couple of closing remarks about polypharmacy in general and how all of this relates. And I'm certainly open to answering any questions thereafter. So just to try to come up with a way of dividing some of the material and making sure that our cases didn't overlap, Sage and I decided to kind of divide up into two general categories: pharmacodynamic interactions. And these are interactions in which either different medications and foods, or herbal substances will tend to interact at the level of mechanism. So either they share the same receptor and target, or they have different receptors, but within the same physiologic mechanism, and can thereby either have additive effects. Sometimes their effects will not be additive, they will be supra additive and have synergistic effects, whereby 1 and 1 don't equal 2, but equal 10 in terms of the effect. And sometimes it's antagonistic. I'll be handling that, and we'll give you examples from my recent practice of each. And then pharmacokinetic interactions, which occur really at the level of processing. So we talk about absorption, distribution, metabolism, excretion, the different phases by which medications will be handled in the body. And sometimes two different substances can interfere with each other's processing and lead to harm through that mechanism. So I'm going to get right into a few cases here. The first one is one that I had while I was on call for the New York City Poison Center somewhat recently. We were called about a 51-year-old man who, so he had multiple medical problems: bipolar illness, spina bifida, for which he had chronic pain, and obesity most particularly. And he'd been prescribed a new psychiatric medication, took the first dose, and about 20 minutes later had acute onset of anxiety, nausea. He started vomiting uncontrollably. He had several episodes of diarrhea. His whole body hurt, and he started to feel shortness of breath. And so he presented to the emergency department. Very agitated, a little bit hypertensive, tachycardic. He was breathing quite quickly, very tachypnic, although he was not hypoxic. And he was profoundly diaphoretic on exam, yawning, had piloerection, and a fentanyl patch on his skin, which he was taking for his chronic pain due to spina bifida. So you might not immediately know what the medication was that he took, or what this interaction was, but clinically, when we see yawning and piloerection, what does it sound like? Yes, in fact, he was in precipitated opioid withdrawal, and quite severe. When we added up all of the features that he had and tried to calculate a clinical opiate withdrawal scale score, It added up to 33, which is pretty significant for him. So what was the medication? It's a relatively new one. It's a combination drug of olanzapine, which he'd been on previously for his bipolar illness, and which I think he thought and his psychiatrist thought might have been contributing to his obesity, which was something that he wanted to get control of. So instead of one medication, the slippery slope started where he was given a combination, yet another medication to deal with a side effect. This is something that's relatively new. It was just approved by the FDA in May of 2021. And how does it work? Well, the samidorphan additive is intended to prevent the weight gain associated with olanzapine, but functions primarily as a mu opioid receptor antagonist, and as such can precipitate withdrawal in patients who are on opioids. It is structurally similar to naltrexone, another antagonist at this receptor, but has some different pharmacokinetic features. It's fairly rapid onset, usually within 15 minutes, although the maximum concentrations are achieved after about an hour. And it has a much longer half-life, almost double the half-life of naltrexone, around 7 to 9 hours. So it can have very persistent effects up to 24 hours. And it also binds with extremely great affinity, probably the greatest affinity of any one of these things that we know so far. So it's going to kick off pretty much any opioid that you can come up with from that mu receptor and cause this withdrawal. This is the package insert. It's clearly contraindicated in patients who are using opioids for this reason. But because it's relatively new, not all of the kind of drug interaction checkers have it. These three did. I think most of them are fairly commonly used. Up to date, by the way, is this uses the same drug database to check for interactions as EPIC does. So this is something that probably would have been flagged, but you'll note this is how they talk about it. They say, summary, samidorphan may diminish the therapeutic effect of opioid antagonists. So it's not exactly the warning that we would like, hey, it's contraindicated because it could kill you. Other kind of common drug interaction checkers that I surveyed didn't even have it, again, because it's so new, most likely, though we know that maybe about a third of important clinically significant drug-drug interactions are missed by most drug interaction checkers. So it's a good resource, but not a perfect resource for trying to prevent drug-drug interactions. So precipitated opioid withdrawal, I'm sure this is some, withdrawal in general is something that most of us have maybe encountered in our practices, particularly if we work in acute care settings. Precipitated opioid withdrawal tends to be a different animal, much more severe and actually life-threatening for patients. There have been quite a number of deaths, mostly related to naltrexone, but we'll have to see what happens with samidorphan. It's usually managed with IV fluids, antiemetics, benzodiazepines, clonidine, plus or minus titration of other agonists, maybe short-acting ones like fentanyl. And interestingly enough, buprenorphine has been kind of emerging as a way to treat this, to manage this, by kicking off the full antagonist and replacing it with a partial agonist at the receptor. And I don't know of any case reports yet of people using it in samidorphan. I think it's too new to know. I had wanted to try it, although in theory, samidorphan should have greater receptor affinity and might be resistant to that substitution as a result. I'd wanted to try it in this case, but unfortunately, the patient was just so unbelievably agitated. And despite kind of full therapy with midazolam, diazepam, clonidine, fentanyl, he really wasn't getting any better and couldn't tolerate being in the bed and the therapy. And so they had intubated him by the time I was able to get on the phone with anyone and talk it through. After the fact, we did make an attempt to reach out to the primary physician and to the psychiatrist who'd been involved in this prescribing to understand kind of what had happened. And, it's not really clear what the cognitive error was, but clearly medication reconciliation could have, or better, more rigorous medication reconciliation, and really reading through the package insert for a new medication in particular might have been helpful to prevent this. And the other thing that I think is interesting about this is that, and we'll see in the next example as well, I think for pharmacodynamic interactions, it's relatively easy for all of us to remember what something is being used for. But when the effects that might be involved in the drug-drug interaction are different from the effects that we're trying for based on the clinical indication for what we're prescribing, it can be easy to miss. This is just a pause. As was said in the introduction, I worked in Ghana for a number of years. And on the left here, you see me planting some small banana trees in my yard in 2017. And less than a year later, I was harvesting bananas and had a whole banana farm in my front yard. Which to me means there's hope for the planet. We're worried about climate change, but we can reforest and we can make a difference. It can rebound, just like our patients can when they come to us really sick. So here's the second case. This is a woman that I just had a couple weeks ago, 49 years old. She has, some risk factors for coronary artery disease. She's getting older, a little bit of hypertension, but relatively well controlled, hyperlipidemia, hypothyroidism. She does have some depression and has been started on an SSRI, sertraline. Used to have GERD, but had stopped taking her omeprazole for a period of a few months because that had been relatively well controlled. Otherwise, she's taking amlodipine, atorvastatin, some low dose baby aspirin for CAD prevention, and Synthroid and the sertraline, which had been prescribed about a few months before due to this depression. And apparently the day before, she had come to our emergency department. At that point, she'd been sick for about 3 days, fever, myalgias, really intense diarrhea, and had a benign abdominal exam, some very reassuring labs. She got some IV fluid hydration, felt a bit better. Her COVID test was negative. And so she was sent home. And then the next day came to us in shock with just multiple and fairly large volume melanotic stool. So what happened? I don't know. It was probably as much an interaction between her physiology and her acute illness, most likely a viral illness. But there is an interaction here that I think we don't often think about and can be clinically significant. Some more recent studies show that it may be a more significant interaction than we've previously thought. Most of the drug checkers that I looked at did come up with this one, and it's an interaction between sertraline, or SSRIs as a general class, and aspirin, or NSAIDs, and in fact, antiplatelets in general. So how does this happen? Well, as we all know, aspirin, NSAIDs are involved in or can be used as antiplatelet medications, specifically for their effects on COX-1. And SSRIs, in turn, block the reuptake of serotonin, which is secreted by activated platelets and involved in kind of supercharging that response and helping them to both aggregate together and adhere to the endothelial wall. And so after a few days of dosing, after about a week, about 80 to 90% of that platelet serotonin store will be depleted because of a failure to reuptake through that serotonin receptor. And as a result, they have antiplatelet functions as well. So how clinically significant is this? Well, this is from a recent systematic review and meta-analysis of 10 studies that was just presented as a poster at one of the large gastroenterology meetings, looking at what happens when you combine SSRIs and NSAIDs in terms of risk of upper GI bleeding specifically. And it shows significantly increased odds of GI bleeding with a number needed to harm of only 12. And subsequently, and more recently than that, just in the last couple of months, an even larger meta-analysis. This one was looking at 32 studies with almost a little over 1.8 million people. Not all of them were doing a combination of antiplatelets and SSRIs. The bulk of the patients in this series were doing anticoagulants and SSRIs versus not. But again, showing when we looked at the antiplatelets specifically and what that combination does, and increased risk of harm. And some of these studies did cross the midline, but the overall effect was significant. I think this is a nice graphic from another study looking at 3 trials together, again, of NSAIDs and SSRIs. Either one alone, what is the risk of upper GI bleeding versus when you put them together. And it's a nice graphic because it shows over on the right that either one alone does have an increased risk of upper GI bleeding, but when you put them together, you get these synergistic effects, a risk that's dramatically higher than either one alone. And furthermore, looking at the ones in the middle, this could be abolished by the use of proton pump inhibitors or acid suppressing agents. So that's, it's kind of unfortunate that her GERD was under control and that her omeprazole had been stopped around the time that this SSRI was started. In a way, had she restarted it and we had decided to go the polypharmacy route and give an extra medication, we might have prevented some of this morbidity in her case. So she did respond very well to resuscitation with packed red blood cells, was admitted, and ultimately on discharge had her aspirin discontinued and omeprazole restarted based on this risk moving forward of additional bleeding. So this is, I actually can't remember which year this is, but this is just a nod to both the enjoyment that we all get from actually meeting in person. This is Sage and myself at judging one of the CPCs at a Indus EM conference in India. And we miss seeing everyone in person, but are really grateful for this opportunity to all stay in touch through Zoom. So the third case I wanted to talk about is, again, something that I see somewhat regularly. This is a 72-year-old woman who presented with a fever, productive cough. She'd had nausea and vomiting for several days. She was short of breath. Her history was significant for hypertension, hyperlipidemia. She did have some coronary artery disease, GERD, and also opioid use disorder, which had been well controlled on a stable dose of methadone for many, many years. She's actually somebody I received in sign out at shift change. And the sign out is, yeah, you know, she's got pneumonia, and we've treated her for that. And she's just waiting for a bed. Oh, by the way, she did also have a seizure at a certain point. We talked to her daughter, and she might have had a remote history of seizure disorder, but is not on any medications for that currently. We gave her some lorazepam. She's fine. It was a busy evening. And so she was actually in the hallway at that point of the emergency department. And about an hour later, I was walking by and noticed that she had another seizure. So at this point, I got nervous and about her being in the hallway, and I'm going to be giving her more benzodiazepines and so forth. So tried to move her into a room to put her up on a monitor. While calling for benzos. And this is what we saw on the monitor. So instead of the lorazepam, we gave her electricity and we shocked her. This is clearly torsade de pointes. And the question is, how did that happen? Well, she had multiple predisposing factors that could have prolonged her QT and put her at risk for this sequelae. She's female, she's an older woman. She most likely had some hypomagnesemia because she hadn't been, eating very well, and hypokalemia from the vomiting due to her pneumonia and to being sick. She was on multiple QT prolonging medications, hit multiple points of risk. We know there are over 190 medications, according to Credible Meds, that fairly reliably or have decent evidence that they do prolong the QT interval. And not all of them have equal effect. So some have fairly low to moderate risk of leading to torsade de pointes and do it, have this effect with lesser or much greater risk. There are some that we know reliably prolong the QT, like amiodarone and verapamil, but don't usually lead to torsade de pointes. Others that have much greater risk. And she was on methadone at baseline, which is considered a fairly high risk drug, and then received both a macrolide and ondansetron as an antiemetic. And we know that any one of these can ultimately do it, particularly in a susceptible individual, but that the risks are increased when multiple medications are given. They're increased in the first week to 2 weeks after a new medication that can prolong the QT is started, or a drug has been up, or the dose has been up titrated. There's greater risk when these medications are given intravenously, especially if they're given at a more rapid rate. And I think she kind of hit the lottery on most of these points. So there's no way to know really, whether someone is truly at risk for torsade de pointes on any of these medications, or whether or not we should withhold a potentially useful drug versus give without just checking. So you got to get the facts, you got to get an EKG, and then of course the question is, what do you do with that information? How do you interpret it? I think she had not had an EKG done prior, and that was a mistake. But many times we will do an EKG and we might still miss it. And this is just to point out that, or to put a plug in for manually rechecking every time using any number of recommended ways of doing that. I think checking at least 3 consecutive beats, recognizing that there's always ever beat to beat variation, is important. Some people recommend checking 6 and doing the median versus the average of 3. But either way, I think manually measuring it and then picking a better formula than what the machine uses, which is the Bassett, is important. This is a QR code that links to Radharaju, which there's some evidence has better sensitivity and specificity, particularly at extremes of heart rate in drug-induced long QT for estimating the, helping you to monitor that over time and in response to various medications. There's also a QT nomogram that can be useful for predicting the risk, though really all this does is allows you to get a kind of quick and dirty sense of whether or not the person is at risk for torsade de pointes based on their measured QTC as a product and their heart rate. What it doesn't allow you to do is monitor and compare that over time, which I think is an important characteristic of important characteristic of the QTC if we actually measure it out. So I'm going to end with that, or with just a couple closing remarks on polypharmacy. I think it is an epidemic. It's something that it affects quite a number of people. Difficult to define. Most definitions, I think, are quantitative, with the idea that anyone taking more than 5 medications daily is someone who is experiencing polypharmacy. And there are clearly some health risks associated with that. The most important from a medical management standpoint is the risk of adverse drug events. You'll notice none of the examples I gave, and I think the same with Sage, relate to a very great number of medications interacting. They were all just 1 or 2 working together. But patients who are taking more than 5 will statistically be more likely to experience adverse drug events. They have an 88% higher risk of these, with about 1 in 2 will experience toxicity from a drug interaction, and account for quite a number of hospitalizations and deaths. But beyond that, I think it's a problem for adherence. Certainly in my population, I think that's true, and poses real financial challenges to people, many of whom here in the United States at least are at great risk of either medical bankruptcy as a result of some of the things we propose for them, or just for worsening of their disease because they can't keep up with the program. So with that, I will open to questions and just say thank you for all that you do. This is a cartoon that came out toward the beginning of the pandemic, and I think it made me feel good, and hopefully it will make you feel good too for the wonderful work that you do every day.
Thank you so much, Sari. That was a wonderful talk. It's an eye opener, really. I hope everyone can hear me. So this is actually such a topic which people do not realize. In fact, let me tell you, one of a very popular TV serials called The Resident, which I watched, last episode focused entirely on polypharmacy, how a person really died because of drug interaction. That's a very, very important thing, which is coming out, because these patients go. I've seen patients who come with literally 60 medications, and my nurses have to go through each of them and put them on the computer. And then also, I mean, that's a real issue. And I'm going to actually now invite Sagar. Sagar is my partner in crime, very great help in my CME committee. Sagar is the founding director and researcher of core faculty of Florida State University emergency residency program at Sarasota Memorial Hospital in Florida. He graduated from Pune University. He's residency trained and board certified in internal medicine and emergency medicine in India and USA. He trained in University of South Florida and holds a double master's in public health and business management. His prestigious fellowships from Royal College of Physicians of UK, American College of Academic International Medicine, American Academy of Emergency Medicine, and Academic College of Emergency Experts of India add to his academic achievements. He is deeply engaged in advancing academic emergency medicine and academic international medicines all around the world. Sagar's 2 decades of work is decorated by many publications, citations, and lectures all across the world, and he has been awarded the prestigious Kazi International Leadership Award of 2022. He is also AAPI Distinguished Award winner twice, once as a resident and once as a young physician. He is a great help, long-term AAPI stalwart, and a he is actually on call today, and I don't know whether he can join in, but if he can, I would like Sagar to join in and moderate the session.
Yeah, I'm here. Can you all hear me?
Yes, we can.
Yes, thank you, Amit. Thank you, everyone, for attending our fantastic CME on polypharmacy. Polypharmacy as a topic has always intrigued me. We started working as a group with Sari and Sage, who have been very instrumental in developing emergency toxicology in India. In fact, the prestigious Dr. Sage and Dr. Sari World CPC competition is named after them because they devised the international format for the CPC competitions, which is one of the most unique competitions held across the world. This year, we held it virtually, and teams from across the world participated in that competition. So toxicology was something which intrigued us for a long, long time, especially polypharmacy, and across the world as generic pharmaceuticals continue to manufacture original medications, the ingredients and the complexities of interactions became more and more convoluted, and hence there was a need in the academic frontier to address this important topic on polypharmacy. And hence Dr. Sage and Dr. Sari and myself started working on this long time ago, that we have devised versions of training and course content regarding this interesting topic. Many publications have also taken place in creating polypharmacy scores. I hope we can soon devise artificial intelligence systems to be able to guide doctors, because it's impossible to remember so many things. Sari, could you quickly go over some interesting pearls of medicines we should be aware of? For example, what I learned, and we all practice in emergency medicine, is if you see a drug with a level, you should always get the level done. So can you go over a quick list of the drugs whose levels are available for us offhand?
Sure. So, part of that depends on what institution you're in. So it's a little bit of a systems-based practice question. I think, and again, depending on sort of where you are in practice, if you're in a clinic and doing a send out, you'll probably have access to more options for therapeutic drug monitoring. I work in a hospital-based setting as you do in emergency medicine, and I think the levels that are available in-house in a kind of rapid time frame are for not for therapeutic drug monitoring, obviously, but we have salicylate and acetaminophen that are rapidly available in the emergency department. We have lithium is something that we get commonly, and many of the anti-epileptic drugs will have levels that can be obtained in a reasonable time frame. Let's see, methotrexate becomes very important for patients on that, since
Absolutely.
It's a narrow therapeutic index, and people can get into trouble with that quite quickly. Digoxin is another one that I think Sage is going to talk about a couple of interactions that are important there, but by all means, that's in most institutions, I think, a level that will come back relatively quickly. those are the ones I feel like I use most frequently in my practice. This isn't a therapeutic drug level, but iron and lead tend to come back in a relatively quick manner. Obviously, no one's dosing anybody with lead, but iron for sure.
With that leg 3 times.
And people can
And
get
a motorcycle or a dirt bike.
Sage, feel free to jump in if I'm.
Yeah, I mean, I think some other ones might be some antibiotics that we don't typically measure in the ED, but on the hospital floors, thinking about vancomycin as one that usually has to be followed, and gentamicin concentrations. I guess caffeine potentially in some settings.
Yeah, or theophylline. Those concentrations are usually available in a pretty rapid time frame. Yeah.
Great. That was great. And Sagar, I can hear that he's in the ER and getting some pages.
Okay. No, but that's fine. Yeah.
Okay,
so Sage, the common practice which is now happening is that patients come from nursing homes, so patients are on these chronic medication therapies, and most of the times we really miss out saying that, oh, we didn't do these drug levels, and you find out that most of the complications happen because of these drug levels. I'll give a simple example. There was a patient who came in saying that, oh, my back is hurting, my head is hurting, and she was extremely diaphoretic, tachycardic, completely at 140, 150, and severe headache, severe back pain, and you think that, oh my God, is there a dissection? Is there a hemorrhage in the brain? And then you do a workup, and then suddenly when you're walking out, you see a low carbon CO level on the chemistry, and that struck me. I said, what have you been taking for pain medications? And he said, well, I emptied a complete bottle of aspirin. And you get shocked, oh my God. And then you do a complete workup, and next thing you know, in a few hours, the patient is intubated. So I think asking patients when they have fever, when they have pain, as to how much medicines have they taken, what have they taken, how many number of tablets have they taken, is equally important in history. Not just saying that, oh, I took Motrin or I took Aleve. How many did you take? In what frequency did you take? I think those questions are equally important even in clinic practice.
Mm-hmm. Yeah, I would definitely second that. I know back in the day, I feel like I saw more of those aspirin cases where people were taking it for pain. Now it's the paracetamol or the acetaminophen that we worry about a lot. So when people come in with arthritis pain, a lot of times back pain, as you mentioned, I agree, getting that more detailed history, and then going ahead and screening and getting an acetaminophen concentration and looking at that together with the LFTs can be really important to not miss some of these cases.
Another good one I heard recently was Bactrim and ARBs and ACE inhibitors, which is apparently Bactrim accentuates the hyperkalemia caused due to ACE and ARBs. That is one of the latest one I heard. And there have been cases regarding that. So, we have to now watch out for Bactrim too when you have hyperkalemia. So I think that was phenomenal, Sari. I think commendable you brought it together. I think we can go on for hours on the polypharmacy.
Yeah.
But,
so there are a few questions on the chat box. If you don't mind, I can go ahead and ask them.
Please do.
Before we go there, Sari and Sage, let me ask you something from my side. I mean, we have got this, let's say, Epic and other software, and it's called I don't know. There's a terminology called interaction fatigue. In other words, any drug you put, either it comes as orange, yellow, or red. And a lot of times there are medications which may not be that important for a short course of treatment. For example, if I give an antibiotic and the patient is on potassium supplementation, then it comes as it's contraindicated. So a lot of times we kind of make that decision and go ahead. But there are a lot of, the pendulum sometimes I feel is more towards the other side, and we are kind of at a loss sometimes as to which ones are important and which ones are not, as a non-medical doctor. So your comments on that, please.
I could not agree more that there are real limits to the utility of some of these softwares. This kind of alert fatigue is absolutely real, where you just kind of buzz through. I know in my own practice, I catch myself doing it every day, where I, what does it say? Risk outweighs the benefit, I think, is the first button on the left that I get to push in Epic to make that alert go away. And I reflexively click on that button without even looking to see what it is that it's alerted me to. On the other hand, when you slow down and you do look at the alerts, I tried to show that example of this is a life-threatening interaction that didn't, really get flagged with any appropriate degree of caution. On the other hand, you might have quite a number of other ones that are not likely to be clinically significant that would be alerted by the system with the same degree of caution, say, or color change, or so I really think the only answer is to keep studying and remember it's lifelong learning, and to learn some of these things and work together to learn from each other's practices about which ones have the greater degree of risk associated, and then be careful with what we do.
Awesome, thank you. I'm going to go over the questions. We've got about another 10 minutes before we go to the next speaker. So first question is that how common are the interaction between SSRIs and NSAIDs?
And so on a population level, I really don't know, and couldn't say. I think, with a lot of these things, we never know what the denominator is. I assume that especially in the wake of the great mental health crisis that has come out of the pandemic, I imagine that the use is much greater, and that therefore the risks and possibly the incidence of major bleeding due to SSRIs or that combination is higher, but I can't give a numeric value to it.
To stay on Highway 67 south.
The data that's available really relates to a kind of percentage increased bleeding risk as compared to people who are not taking SSRIs and who are taking chronic NSAIDs or vice versa, but doesn't give a population basis for understanding it. But I think it's nonetheless, interesting, and something that we may see sort of a greater alert urgency about in the wake of these new meta-analyses.
Yeah, that was from Deepijan Mohapatra. We've got another question from Sudhir Vasudevan. He asked about generic drugs. So basically, he's asking us about where do generic drugs cause more drug-and-drug interaction? And my follow-up question on that is that well documented in all these systems? Your interaction Epic systems and stuff like that. Do they give equal weight to generic drugs interactions?
Yes. So I think my answer to that question would be that it depends on your practice environment. Generic drugs, as opposed to, kind of brand name drugs, should not, in most countries, pose a differential risk because the mechanism would be the same. That said, I think in many countries, certainly where I practiced in Ghana, we had a big problem with counterfeit medicine. And so what we found was that the generic versions were very frequently kind of, sugar pills or some very inexpensive tablet that had been packaged in a box to make it look like whatever it was. And so we had a lot more problems with generic medications either not working or containing contaminants or adulterants that put the person at risk for some toxic sequelae or other interactions that you couldn't guess because you didn't know what the actual identity of the drug was. It was not the thing on the label, if that makes any sense. So in that sense, on a global scale, generics may be more subject to adulteration or contamination in some practice environments and thereby pose risks. But other than that, no.
Yeah, and that's what I tell my patients when they ask about generics. I said, look, it's not FDA regulated, so I cannot give an opinion on that, and it's your call. So that's what I leave it at. So we've got only a few more minutes left. There are several questions. Ravi Kohli, our president-elect, asks about any comments on serotonin syndrome, which is a major concern, and we get alerted all the time. And we cautiously continue to do the polypharmacy despite this.
Yeah. So I absolutely love this term, cautious polypharmacy. I think, in and of itself, if medications are indicated and they are they're going to treat a real illness that is not amenable to other types of interventions, then polypharmacy can be rational. It can be productive for people. It can be useful. In and of itself, it's not necessarily harmful per se. Serotonin syndrome would have been maybe the other one that I was considering doing as an example, as opposed to the QT of this kind of additive effect. Usually there's so many different medications that have these properties. Usually when we actually get serotonin syndrome, the full blown, hyperthermia and so forth, and muscle problems, it's from multiple medications that are acting on kind of different aspects of serotonin release or reuptake together. But I have honestly seen it just from a single drug and not from multiple drugs. So I think the answer here to preventing it is the same as the answer for the long QT or for kind of anything else, that using cautious polypharmacy and starting low, titrating doses slowly, and really monitoring the person and speaking to them about what they should be doing to self-monitor is the answer, rather than withholding on spec, but certainly exercising care and monitoring closely.
Yeah, I agree with that. In fact, there are a couple of more important questions, but a comment on that is when I speak on this anticholinergic medication for overactive bladder, I realized that there was a host of medication which has got some anticholinergic effects, including Lasix, for example. How many people knew that Lasix also has some anticholinergic effect? And all these medications add up and cause this a combination of this anticholinergic effect and makes it worse. And that's how polypharmacy it's in a different form. And this doesn't stand out as a drug-drug interaction, but knowledge about this is important. There's a question from Dr. Chirunomola. Is any input on the host of fixed combo medications available and widely used in India by practitioner against, in addition to highest degree of polypharmacy, even for simple ailments. He points this to India, and I've seen that. My friends, when they send me a medication list, it's a page long for even simple ailments. Any comments on that? Sorry.
Yeah, the combo medications, I've just shown you an example of a dangerous one. It can be difficult because we forget then what the different components are and what else they might interact with. In an ideal world, they're meant to simplify regimens. But if we're going to add on a million other things, then we've missed the boat on that. And Right. So I think the intent with combination medications is to try to circumvent this problem of asking people to take multiple things throughout the day, which is dangerous for the side effects. And as I mentioned in the end there, the increased risk of adverse drug events, either side effects from the individual medications or these interactions. And in addition, can be just overwhelming and exhausting for patients and make them kind of want to move away from interacting with physicians and go back to herbal or, do home remedies, that type of thing. They might not see us as much because they're worried about it. It can be a huge financial strain. I'm sure in India that's the case. Certainly in the United States, I think there are like 8% of people in the United States don't take their medicines just because of financial reasons, and this in turn contributes to disparities in access to health because it's overwhelming. So deprescribing is important, and just working with people, I think educating providers about those risks is probably the best that we can do to try to limit that sort of thing.
Thank you. A comment by Dr. Lina Gupta. She says that a lot of times the patients do not volunteer the over-the-counter and generic prescriptions they take or drugs they take. A lot of times they don't do that, and history taking is very important. That point is very well taken. Dr. Alka Patel says that most EMRs will notify you about drug interactions. Dr. Patel, I think Sari has already alluded to the fact that we get maybe a little fatigue, and I hope that answered your questions. The question from, we've got about 4 minutes left. Somebody wants you to repeat the point about generics being inadvisable. That's Dr. Khan. Can you just quickly point that out? And then we have got one more question before we proceed. So you said generics are inadvisable. Just could you repeat that point?
Good. So thank you so much for that. I really do not want to say that generics are inadvisable. I think especially here in the United States, where there are quality controls and some degree of monitoring of the actual production of pharmaceuticals, where generics are held to some companies that produce generics are held to standards as to what they put in, and that there is the correct identity of the medication and the correct dose as it appears on the package, so that you can feel with some degree of confidence that you know what you're getting. I think it's there's no reason to believe that they wouldn't work just as well as a brand name. My concern was that in countries where there is less regulation and oversight of medications that are being usually imported from elsewhere, there can be some contamination of the supply with people who are selling things that are not actually the medication. So you've bought, let's say, an antibiotic, and it comes in a generic package, but the pill itself is not actually an antibiotic. It's it's Tylenol or something like that that's been repackaged. That was the problem a lot of times in Ghana. But in and of itself, generics should contain what they say they contain at the right doses and should be fine.
Okay, well, I mean, actually, Ravi Kohli, Dr. Ravi Kohli comments that generics, 90% of the generics, and as all of you know, Good RX is one company which gives you those medications at quite cheap rates, and that's absolutely true. But he also asks, you can make a comment on that, but he also asks, can you also comment, there are a lot of food substances which have interactions with medications. How do we prevent that, or how do we, is there any light you can shed on that?
Sure. I mean, it's this is absolutely true. So, food-drug interactions are important, and herbal medications can also interact with many of the allopathic medications that we're prescribing. If you think about, St. John's wort and many of these other things that people would be taking might interact with their prescribed medications. And there's no kind of across-board one principle that would help us, I think, remember these. It's more a matter of, I think, talking to our patients about what else they're doing to self-treat, who else is helping them with their manage their conditions, and asking them about what they're eating, and just getting to know very well each of the medications that we're going to be offering to them and prescribing them, so that we would know on a case-by-case basis how to advise.
Awesome. Thank you so much, Sari. That was a very it's an eye opener, and it's something which we all face on a day-to-day basis. And like I said, like I told at the beginning of the CME, we are trying to get all the CME topics this year, which will be applicable to all specialties across the board, so that everybody gets to learn from this rather than being specialty specific. And you have addressed this very, very common problem so eloquently. Thank you so much. And I really appreciate you joining us. And let's go to our next speaker. Sage Wiener attended the medical school at Albert Einstein College of Medicine and completed a residency in emergency medicine at Jacob Medical Center. He completed the fellowship in medical toxicology at New York City Poison Control Center in 2004, and has been a faculty in the Department of Emergency Medicine at SUNY Downstate Health Sciences University and NYCH plus H, Kings County since then. He has served as a director of medical toxicology, director of first, second year emergency medicine student education, director of SUNY Downstate ED opioid overdose prevention program, naloxone distribution program, co-director of NYCH plus H Kings County ED forensics fellowships, chair of the Pharmacy and Therapeutics Committee in both these hospitals, and course director of medical toxicology elective. Since 2007, he and Dr. Sagogian have been deeply committed in the education of emergency medicine and medical toxicology in India, running workshops in toxicology with Indian colleagues at the Indus EM and WACEM, giving numerous lectures, serving as judges for the research competition and photo competition, running the annual CPC competition, which Sagar had alluded to. Wow, that is absolutely a mouthful. And this is, I'm sure, the tip of the iceberg of his resume and CV, which I've already gone through. We are so grateful to have such delightful and such well-learned speakers for us. So over to you, Sage.
Thank you very much for that introduction. Let me just put my presentation up. Okay, is everyone seeing that? Great. Thank you for giving me the opportunity to speak today. And I'm also going to be talking about polypharmacy challenges. Sari was focusing on the pharmacodynamic interactions that can occur, and I'm going to focus more on pharmacokinetic interactions. And she alluded to the fact that can affect absorption, distribution, and elimination. And I'm going to be mostly focusing on the elimination part of that, which I think are the most common types of interactions that we're going to encounter. I do want to mention that I don't have any conflicts to disclose. So our interest in teaching in India, I think, started in 2007 when we first started working with Indus EM. And this is Sari and I with two of our colleagues from India, Praveen Agarwal from AIMS and Ashish Bala from PG Eimer in Chandigarh. And we've been teaching this toxicology workshop every year for since 2007, basically. And it's just something that we're very committed to. And so, yeah, this is just showing all the, we basically started the third year of the conference in Mumbai and have attended everyone since then. So just to, as an overview, I'm going to talk a lot about P450 interactions, which I saw in the chat, people starting to bring up during the question and answer session from the last lecture. I'll talk about some interactions that can occur by alterations in your gut flora. And then I'll also spend a little bit of time on excretion interactions, talking about biliary excretion, renal excretion, and P glycoprotein interactions. I'll introduce each one with a case similar to how Sari did. And I'll start with this one. So a 36-year-old woman with diabetes is treated for urinary tract infection. And several days later, she's found to be lethargic and confused. These are her vital signs. She's normotensive but tachycardic and doesn't have a fever. She has a good saturation and she's drowsy, confused, but she is arousable. She's diaphoretic and mildly tachycardic, and the rest of her exam is otherwise normal. So she gets a finger stick glucose and it's 43 mg per deciliter. So she gets some IV dextrose and her mental status and her physical exam normalize. So I think probably some people may be clued into what may have occurred here, right? The patient was on glipizide, sulfonylurea, and was prescribed trimethoprim sulfa or Bactrim. And so the interaction here is a P450 interaction. Glipizide is a CYP2C9 substrate, and Bactrim is a CYP2C9 inhibitor. So this is just one example of a P450 interaction. So let's talk about what these types of interactions can be. Xenobiotics can be substrates of P450. They can be inducers or inhibitors of P450. And when you have a patient who's on a substrate and gets put on an inducer or an inhibitor, then that can either increase or decrease your serum concentration. And it's important to remember that there's a lot of different isozymes of P450 and that these are specific which medications that they're involved with the metabolism of. So just review our basics of biotransformation, that when we ingest fat-soluble toxins, and remember all medications are toxins, they typically will undergo phase 1 metabolism, although you can have phase 2 without phase 1. And phase 1 will add on some type of functional group. We can see oxidation reactions, reduction, hydrolysis, hydration, dehalogenation, and then phase 2 is conjugation reaction, and that will typically add on a larger molecule that typically is going to increase the water solubility of the drug, with the exception of methylation, and that will help these drugs be eliminated either by the gallbladder or by the kidneys. So we're going to talk a lot about these P450 interactions because these are probably the most common ones that are going to affect the elimination of medications that patients get prescribed. So we can see reduction reactions, oxidation, hydrolysis, and in typical, if R is the drug, what typically will happen, as an example here, we'll use reducing potential from NADPH with a hydrogen ion and oxygen, and basically make water and add a hydroxyl group onto your R group, which is the drug that we're talking about. So that's just one example of a P450 reaction. And in general, P450 metabolism creates polar water-soluble metabolites. And in general, P450 metabolites are still active compared to when we conjugate. Typically, those drugs are no longer active once they get conjugated. It's also worth keeping in mind that some metabolites from P450 might be toxic. So when we take a dose of acetaminophen, when it undergoes CYP 2E1 metabolism to N-acetylparabenzoquinonamine or NAPQI, that can cause hepatotoxicity. So I've been mentioning these isozymes and not really talking about how they're defined. So there's families and subfamilies of P450, and it's worth remembering that the families are numbered, the subfamilies are lettered, and I think that's just where that comes from. I don't think it's that important, but it is important to recognize some of the heavy hitters that are involved in a lot of interactions. So 3A4, 2D6, 2C9, 2C19. 2E1, 2A6, and 1A2 are kind of ones that are frequently involved in drug interactions. And so here's some examples of interactions that might occur. So patients on theophylline, which is CYP1A2 substrate, if they're on an inducer of metabolism, like cigarettes, if they quit smoking, then that potentially can wind up increasing their serum theophylline concentrations. So people were talking about drug-food interactions and drug herbal interactions. I think you can view tobacco smoke as sort of an herbal product in a sense. So that's a non-pharmaceutical that potentially can affect the serum concentration of a pharmaceutical. Or a patient might get put on erythromycin, and that can inhibit the metabolism of theophylline, and that can increase their serum concentration. So that's just one example. Looking here at some food interactions, we can see alcohol as an inducer of 2E1, and remember that halothane or acetaminophen are substrates of that, whereas disulfiram is an inhibitor of 2E1. Another one that it frequently comes up is grapefruit as a 3A4 inhibitor. That can wind up increasing the concentration of a number of medications. So these are examples for each one. There are obviously tons of examples out there. This is a table just looking at one specific type of CYP enzyme, 3A4, and the first 6 columns here are all substrates of 3A4. The next 2 columns are inducers, and then the final column are inhibitors of 3A4. And I do want to highlight some things that these interactions aren't necessarily inherently good or bad. They're interactions that can increase or decrease serum concentrations, and sometimes that can be used for therapeutic effect. And I like to give the example is I'm a big enthusiast of coffee. And I like to drink my morning caffeine. And I know that if I take an inhibitor of CYP3A4, grapefruit, that's going to give me more bang for my buck out of my morning coffee, because I'm going to inhibit the metabolism of that caffeine. Or if I want to be fancy, I can take some pomegranate juice. Another example of an interaction here, oral contraceptives are substrates of 3A4. And if a patient gets put on an inducer of 3A4, like dexamethasone, that can wind up increasing the metabolism and leading to a more significant interaction, which is that their oral contraceptives are subtherapeutic and the patient can wind up with pregnancy. So Sari highlighted some of the limitations and some of the potential benefits of using an interaction checker. I think it's important to do. I'm just highlighting here the Hippocrates one because that's the one I typically use, but this isn't necessarily the best one. It's just one that I use because I have it on my phone already. And so I think people often use this for looking up medications using that top left button, but they may not even realize that they have this interaction checker built into the app. So you can put in, ciprofloxacin and amiodarone, and it'll tell you that there's an interaction there. If you click on it, it'll tell you what the interaction is, that you can increase the concentration. There's a risk of QT prolongation. So it doesn't substitute for clinical judgment. You have to make a clinical decision about whether this is a clinically important interaction. But at least it'll, especially for people in training, I think it's particularly important to at least make people aware that an interaction exists. And especially for the P450 interactions is one area where I think that these are particularly useful, because I think that there's just no possible way to memorize every one of these interactions. You know, I think for some things, that some of the pharmacodynamic interactions, you can be aware of what drugs are serotonergic and potentially can interact because we have to understand the mechanism of action of the drugs that we use. But the P450, which isozyme is involved in metabolism of every single drug that a patient might be on, is a lot more challenging. And you really do need to look these up. Okay, next case. 47-year-old woman with epilepsy is treated for traveler's diarrhea. 3 days later, she presented to the emergency department after having a generalized tonic-clonic seizure. While in the emergency department, she has another episode, and she gets treated with lorazepam with resolution of the seizure. And her vital signs, she's a little bit tachycardic and tachypnic, but has a good saturation and is afebrile. She's postictal and drowsy, but arousable. Otherwise, a normal neurological exam, and the rest of her physical exam is normal except for the vital signs. And it turns out that she has epilepsy and is supposed to be taking Tegretol, but her serum carbamazepine concentration was subtherapeutic. So she was on Tegretol, but got put on ciprofloxacin for her traveler's diarrhea, and CYP3A4 inducer of ciprofloxacin increased the clearance of the substrate carbamazepine and lowered the concentration to a subtherapeutic one. All right, so that's just another example of a P450 interaction. I'll give you another one. An 86-year-old woman with hypertension, congestive heart failure, atrial fibrillation is treated for urinary tract infection. And several days later, she's lethargic and confused and has some nausea and vomiting. Her physical exam is significant for some bradycardia with a heart rate of 54. The vitals are otherwise okay. And she's drowsy, she's confused, but arousable. And on her cardiac exam, she has an irregular heartbeat. And the rest of the exam is normal. And this is the electrocardiogram. So I think probably a lot of us, depending on what our specialty is, might recognize this as a pretty classic electrocardiogram that we might see in the setting of digoxin toxicity. Right, so we see atrial fibrillation due to the irritable myocardium with a slow ventricular response because of the vagal effect of the dig. And you can also see in the lateral leads here some that slurred ST depression that's kind of typical for dig effect. So this is a patient that was on digoxin and got put on amoxicillin clavulanate. And this is a different type of interaction. This isn't a CYP interaction, but this is an interaction due to changing gut flora. So that amoxicillin clavulanate kills your intestinal Eggerichella lenta bacteria. And normally, those bacteria in the intestine are responsible for metabolism of part of an ingested dose of digoxin. And so when you kill off those bacteria, some of the drug that would have been metabolized before it was absorbed, that doesn't happen. And so you wind up increasing your absorption of the drug and increasing your serum concentration. So this is an example of a gut flora interaction. These can occur in either direction. So gut flora for some medications can metabolize a drug to activate it, to convert a prodrug to the active form. So like sulfasalazine is an example of that. They can metabolize a drug to the inactive form. So digoxin is an example of that. Or they can bind to a drug and prevent it from being absorbed. Or an example is levodopa can be metabolized to dopamine by intestinal flora and prevent its ability to get into the brain. So specifically for digoxin, classically the bacteria were known as Eubacterium lentum. It's been reclassified, and the new name for that bacteria is Eggerichella lenta. And this is a common one that can be killed off by quite a few antibiotics, and that can affect your serum digoxin concentration. So if you do have patients that are still on digoxin, it's just really important when you're thinking about treating an infection to see whether this is a potential interaction. But digoxin isn't the only one. I mentioned several others. Lovastatin potentially can be affected. And there are some others that is suggested as possible interactions with gut flora. Montelukast, duloxetine, aripiprazole, sulfasalazine, some chemotherapeutic agents. And this is still an evolving area. There's undoubtedly other interactions that have not yet been identified. But it's definitely something to keep an eye on as we get more information about that in the future. Next case, a 45-year-old man with epilepsy is diagnosed with hyperlipidemia and fails to control it with a low cholesterol diet. He started on a new medication, and several days later, he has a seizure at home and another upon arrival to the emergency department. His vital signs are pretty normal. He's afebrile, he's a little bit tachypnic, and he's postictal and drowsy but arousable, and the exam is otherwise normal, no focality. And he has a serum valproic acid concentration of 22 micrograms per ml, which is subtherapeutic. So what happened? Well, he was on Depakote, divalproex, and got put on cholestyramine for his hyperlipidemia. And normally, divalproex gets enterohepatically recirculated, but cholestyramine can bind up that valproic acid and prevent its reabsorption from the bile. I'm going to do two more excretion interactions here, and then I'm going to talk some more about all of them because a lot of them have things in common. So next case is a 37-year-old nurse with mild hypertension and familial hypercholesterolemia, and she's volunteering for Médecins Sans Frontières in Haiti, and she gets a hollow needle stick in caring for a patient, and so she's given post-exposure prophylaxis for HIV with a standard 3-drug antiviral regimen. And over the next several days, she starts to feel weak and has some myalgia, and she gets reassured that by the doctor that this is a common side effect of that post-exposure prophylaxis. And over the next 2 days, her symptoms get worse. She has more severe myalgias, nausea and vomiting, and has some brown urine. Her physical exam she has essentially normal vitals. She has generalized myalgias and dark urine, but otherwise a normal exam. And she gets some labs and has an elevated CK, elevated LFTs, and elevated creatinine. So what happened? Well, she was on rosuvastatin and got put on Kaletra or lopinavir-ritonavir. And ritonavir increases the rosuvastatin levels by decreasing the urinary excretion. Next case, 56-year-old woman was taking digoxin, fluticasone MDI, and salbutamol, and she is visiting Kenya with family. And after 5 days, she develops diarrhea while camping. And the guide gives her some medication for possible malaria. And 2 days later, she develops severe nausea and vomiting. And the following day, she's too dizzy and weak to walk and then becomes unresponsive. So her physical exam is significant for bradycardia. She's alert, but she's weak and she can't really stand. And over the past day, she's had 16 episodes of vomiting. Her labs are significant for some hyperkalemia. And this is her electrocardiogram. So similar to our previous DIG case, we see some slow atrial fibrillation here with some DIG effect. And her DIG concentration was 4.2, so pretty significantly elevated. So this is an example. The patient was on digoxin, was not really prescribed. She was given quinidine by the guide for presumed malaria. And quinidine is a P-glycoprotein inhibitor. And so that does a number of things. It increases absorption and decreases excretion of digoxin. So let's talk about all of these excretion interactions that I just highlighted with some cases. So we think about excretion in the renal or the bile. And you can either have increased or decreased excretion. You can have increased or decreased reabsorption in the kidney. And those can all affect your ability to eliminate a drug. In the bile, you can wind up decreasing excretion. You can also decrease the reabsorption, either of the drug or of a metabolite. In terms of urinary excretion, there are a number of transporters that are involved. There's the OAT1 and OAT3. They're involved in excretion of certain medications into the urine and the proximal tubule cell. And so things that can affect that include aspirin and probenecid that can wind up increasing concentration of some drugs. Also, we can inhibit reabsorption by blocking the URAT transporter. And then finally, another important element of elimination is P-glycoprotein. And so P-glycoprotein is in a number of places in the body. One of the important ones is in the intestinal lining. It basically, in general, P-glycoprotein is an ATP-driven channel that pumps xenobiotics out of the body, is a way to think of it. In general, it pushes things out and protects the body. So in the intestine, it will basically pump drug out that has been absorbed and put it back into the intestinal lumen, so to kind of decrease the absorption and the bioavailability of a drug. You can also see P-glycoprotein in the blood-brain barrier to keep drugs out of the brain. You can see P-glycoprotein in the liver to pump drugs into the bile. And P-glycoprotein is also in the proximal tubules and will put some drugs out into the urine. So this is responsible for an increasingly recognized number of interactions. So here to just highlight some of the renal and P-glycoprotein transporters and potential interactions here. So the quinidine and digoxin example, you can wind up increasing your digoxin concentrations because of P-glycoprotein inhibition. Rifampin and digoxin is also a potential interaction. And in this case, rifampin is a P-glycoprotein inducer. So that's going to wind up having the opposite effect on your DIG concentration and can make it subtherapeutic. Dronedarone is another inhibitor of P-glycoprotein. And then we can get into some renal transporters. Probenecid is kind of a classic one. And in fact, that's been used for therapeutic effect to increase serum concentration of some antibiotics. Cimetidine, in addition to having a lot of P450 interactions, potentially can affect your organic cation transporter, and that can lead to increased concentrations of metformin. And cyclosporin is an interacting drug for rosuvastatin, and that can wind up increasing your rosuvastatin concentration. And the other example that I gave in the case, the lopinavir-ritonavir combination is an OAT-P inhibitor, and that can increase your rosuvastatin exposure and double concentrations. So there are a lot of drugs that affect P-glycoprotein. There's a lot of inhibitors, or most of them, but there are two inducers. And here I'll highlight because people were interested in pointing out potential interactions between drugs and herbals. And St. John's wort is a P-glycoprotein inducer, and that can lead to subtherapeutic effect of a number of medications. And then there are excretion interactions in the bile that I highlighted with the valproic acid example. And in general, things that are bile acid sequestrants like cholestyramine or cholesterol are basically going to decrease the concentration of anything that gets secreted in the bile. And so there's a long list of these here. And these tend to be clinically relevant. So, I mean, it's, I think, probably one of the main reasons why these are less and less used, because there's so many interactions with things that patients might be on. Okay, so to sum up, P450 interactions can lead to increases or decreases in serum drug concentrations, and sometimes that can be something that's therapeutic, but more commonly, it can wind up being a problem leading to either subtherapeutic drug concentrations or toxicity. Gut flora is important in metabolism of some drugs, only a handful right now, but that's an area that is definitely evolving, and we'll probably be recognizing more drugs that are affected by this. And keeping in mind, anytime you prescribe an antibiotic that can eliminate gut flora, that potentially can have an effect on your drug concentrations. Keeping in mind that there are drugs that interact with biliary or renal excretion, whether it's through one of the specific transporters or through P glycoprotein, and that can lead to increase or decrease in serum drug concentrations. And then use an interaction checker, just always really important. This is my wife and I at the Ganesh Festival in Mumbai, our first year attending INDUCM. Really made me want to go back, and went back the next 10 years in a row. So now I think we have time for some questions.
Yes, sir. Thank you so much, Sage. You're just, this is, again, a great talk and an eye-opener for many of us. I would, again, invite Sagar, if he's available, to kick off the question and answer session.
Hello. Thanks, Sage. Thanks for the phenomenal talk like you give it every year and every time. I think the interaction problems are not only restricted to emergency medicine, but all the departments. Now, from your experience, Sage, have you ever seen a drug interfering with a non-drug? That means patients who are taking herbals, or patients who are taking all these vitamins, and patients who are nowadays in Sarasota, we see all these infusion centers where they are trying to give all these medications. Have you seen medications getting affected by these adjuvant therapeutics which are not listed in pharmacopoeia? Have you ever come across those?
I'm trying to think of an example. I mean, I think St. John's wort is probably the most common example of something like that can affect a lot of drugs, serum concentrations. I'm trying to think if there's any others. Sari, can you think of any? I'm trying to think if I've encountered any clinically. Obviously food drug interactions are big ones for P450.
I've heard one of the ones which I hear a lot about is the niacin flush syndrome. Do you see that often?
I can't say I've seen it often. I've certainly seen it. Yeah, and I'm trying to think of interactions that lead to that. I think people take high dose niacin are likely to get a flush. I can't think of an interaction that leads to that being more commonly, but okay. Obviously the treatment for that is aspirin and will decrease the symptoms. But I mean, I guess in a sense that's an interaction, and the aspirin will prevent that toxicity. But I can't think of an interaction that makes that more likely. Do you have one in mind, Sagar?
No, I was thinking, because it's very difficult to point out patient comes after infusions with these hypotension kind of features, or they'll come in with extreme fatigue, or they'll come extremely, sometimes I have seen patients who become delirious after those infusions, and then they're okay in 3 to 4 hours. So really, it is very difficult. Nowadays, these new types of drinks which are coming, which have high caffeine content, high glucose content, they also alter a lot of medication doses. So I just didn't know whether we have any case reports on that effect in literature. I've tried to search, but I have seen patients where after 2-3 Red Bulls coming with delirious symptoms.
And I think actually that it's even more common with things like 5-hour energy that are really concentrated, and so it doesn't take a lot of volume to get you to a high dose. Yep. But I think it's more common to have an interaction where something is taken that is going to increase a pharmaceutical than the other way around, where a pharmaceutical is going to increase or decrease a concentration of something that's kind of not a pharmaceutical. I'll just put it that way.
The other thing is, what's your experience with Coumadin and altered Coumadin levels with interactions? Because Coumadin is very common now always been common. So do we still encounter those therapeutic problems when they eat these food products or eat different kinds of meals, and then the Coumadin levels go haywire?
So absolutely.
there,
I mean, that's one of the drugs that has the most interactions, and it has both pharmacokinetic interactions like P450 interactions, as I was talking about. That has a lot of different P450 interactions, but it also has pharmacodynamic interactions in that people who have diets that are high in vitamin K, that potentially going to make your Coumadin subtherapeutic, or if they previously had high vitamin K and abruptly change their diet, it can go in the other direction. So it's one of the most difficult ones to manage, and I think one of the things that drives a lot of people to want to use DOACs, because they don't have to monitor the drug as closely as you do with warfarin.
Phenomenal. Thanks, Sage. I think these were, because one of my biggest challenges is that we have in emergency medicine, we don't hardly get any minutes to analyze whatever patients we see, and drug interactions has suddenly become a very important factor in emergency medicine as well as critical care, because the polypharmacy is profound. And I think this will be a separate fellowship soon, with the number of medications we are loading onto patients. And
the patients we see in the ER are kind of tend to be the sicker ones who tend to be on more medications. So it definitely, and a lot of people get sent home on new things. So you have to be really careful with your medication reconciliation.
Yep. And nowadays, I don't know whether you all have started it, but we have a point of care pharmacy. Do you have point of care pharmacy in your departments? So we have pharmacists sitting in the emergency department. We call it POC pharmacy. That means they are looking over every order, every interaction, and alerting the doctors. They even take care of the scripts which are going out and scripts which are being called in.
Yeah, so they're a phenomenal resource if your hospital can afford them. And I think it's probably worth making the argument that they probably prevent enough errors that they pay for themselves, in the number of errors that they cause, and the potential cost of those.
We have 24/7 coverage with at least 5 pharmacists in the ED. So 2 interns and 3 pharmacists. So they are looking over every dose, every like TPA administration. Do we have any other medications which will interact with us? Because that's a disaster. Like patients are being put on Coumadin outpatient, and the patients don't know why they are taking it.
Yeah, they're a fantastic resource for preventing these problems, and also for educating patients at discharge about medications they've been put on.
Correct. Medications. I hope the primary care practitioners also could avail such resources one day, because they take away a lot of load away from the doctor's brain in order to make sure that the interactions don't happen, or they happen, and what are the doses which can affect those. If there are experiences in the crowd who's listening to this CME about point of care pharmacy, I would love to hear it from them too, because we're going to publish this data very soon of 24/7 pharmacy coverage in emergency departments. It's phenomenal outcomes which we have seen in our data.
Yeah, and I mean, this is really their area of expertise, even more than physicians. And I think it's important, just like listening to an experienced nurse, that when a pharmacist brings something to your attention, to not see it as an obstacle or as an annoyance, but someone that's trying to help you, and taking a moment to listen to them and hopefully prevent you from doing something dumb.
Absolutely. All right, Dr. Amit, if there are public questions, or your comments, please.
Great. Thank you, Sagar. As usual, you bring out great points and great moderator. Actually, I'm very, very pleasantly surprised to hear about your pharmacists helping you in the ED. We do have we sometimes get calls from our pharmacists, like in Walmart pharmacy or Walgreens or anything. Sometimes they call us saying that, hey, doc, this. They obviously call you for any allergies that you have missed, but they also sometimes call you, some astute ones actually call you and let you know that, hey, this says that this got a little interaction, what do you think? And stuff like that. And we do listen to them. And I agree with Sage that they are there to help you and educate you, and you should take it in that spirit and not be of any resistance to that. So great talk, Sage. A lot of questions here. So let me go over that. Before you started the talk, I think this is directed to both Sari and you, Dr. Murthy Gokula, who runs a big health wellness clinic, and he is completely committed to that. He actually asks about pharmacokinetic and clinical practice in de-prescribing in the USA, and whether there are any apps to help you to cut down on the prescriptions, because we have seen patients going to different doctors getting prescribed different medications when the left hand doesn't know what the right hand is doing. And sometimes finally we send them to one good internal medicine physician who actually evaluates all the medications.
We are losing you, Amit. We can't hear you.
Yes,
Hello,
he
Amit.
passed through a valley in his car.
Sagar, you want to continue?
The best part of EMR is integration of PBM pharmacy benefits, so that we can, one click of the button, we can know all the prescriptions they're taking. That really makes a big difference in our practice of medicine. That's one silver lining.
Yeah, I think, you know, that opportunity for medication reconciliation. I mean, it's very difficult in Sari and Sagar and my practice setting in the emergency department, where we don't know the patient as well, and it's, you know, we do medication reconciliation, but it's not usually the time to start taking somebody off a whole bunch of medications, and that's really best reserved for the doctors that know them well. But that's one way that we can try to prevent some of these things. I agree, is trying to take people off medications that they don't know. And I think somebody is saying something about the EMR and the integration of that. And you know, that is true. Although sometimes the EMR can cause problems because of bloat of their medication list. So somebody once prescribed them an antibiotic for something, and then that stays on their medication list for a long time, and then it winds up bloated with all these things that they're not on. And if somebody's not taking things off their list that, you know, they were prescribed a short course of, it becomes, you know, the interaction checker that's built into your EMR. It can be really limited in how useful it is sometimes. Depending on what you use. I mean, I think, you know, I use Epic in one of my institutions, and that's great. In the other, I use HealthBridge, and is a lot more limited as its ability to help you with these things. I think another thing that's useful as more of a systems level, you know, I'm the chair of my hospital's pharmacy and therapeutics committees. And when you're making formulary decisions about your hospital, trying to anticipate potential drug interactions, and when you're choosing between different medications to carry that may have the same mechanism of action, looking at ones that have fewer interactions, whether they're P450 interactions, to just try to limit the potential problems down the road within your hospital system. And not, you know, we think about, you know, what is the evidence for benefit of this drug, and we think about the cost comparison, but it's also taking a moment to think about potential interactions and trying to prevent them that way. So I think that we lost
Amit
moderator.
and we moderator. So
I can look at the chat here.
Let me, yeah, I think you can look at the chat, or I can also open the chat box. So I think most of the questions, I think you already answered. I don't, you answered.
Oh,
the
here,
Lina
this is
Gupta.
interesting. So identifying patients with certain genetic makeup and are more predisposed to drug-drug interaction.
Oh, yes. Oh, yes. We see that
and,
often.
And certainly, I had another case that talked about the kind of as pharmacogenomics, in a sense, the polymorphism of P450 and how that can affect drug concentrations. And certainly there are some people who have lower levels of certain CYP isozymes or increased levels in CYP isozymes that can lead to toxicity or to subtherapeutic effect. It's interesting because even it can get kind of philosophical into in terms of what we even think of as a toxin versus what we think of as a genetic disease. And an example that I heard one of my toxicology colleagues talk about that I like a lot is thinking about the disease phenylketonuria, right? So if you have phenylketonuria, you can't metabolize phenylalanine. And so it's a pretty rare genetic disease, but just imagine a thought experiment that it was really common and 99% of people had phenylketonuria. Then we wouldn't call phenylketonuria a genetic disease. We would say phenylalanine is a toxin. And so the idea of what's a toxin, what's a genetic disease really has to do with the prevalence of different polymorphisms. So that, I think that that's kind of an interesting way to think about it. And we all have kind of a profile of our P450, and maybe that'll be something that in the future will be part of our decision making about prescribing, because we'll potentially have a pharmacogenomic profile of our patients.
Did you see that? Don't we see that often in epilepsy patients that, some patients react very well to the anti-epileptics and some don't. Some need more higher levels than others don't.
Yeah,
and some respond to it.
I think codeine is another good example of a drug that's CYP2D6, I think. Sorry, correct me if I'm wrong. Metabolism, and if you're a rapid metabolizer, then you're going to get good metabolism of codeine to morphine and get some good pain relief. But if you're of European origin, maybe 10% of people are going to not be able to do that metabolism so well and are just not going to get any pain relief from that medication.
We see that often in anesthesia. Some of the patients react very well to morphine, some don't. And even I think there was one case where the kid had a dental procedure, went home and died. So I think it's because of the morphine which got metabolized. And so that's a dangerous one in children with these rapid metabolizers. Yeah.
So basically, go ahead. Sage, the point which you're making here, I had presented a paper at the American Urological Association 4 years ago on testosterone metabolism. We found patients, that time we were giving testosterone pellets on these patients, and some patients needed their testosterone pellets much more frequently, and the others did not, had maintained their levels when we tested them. And for doing that, we did this study. We did the genomic studies and found out the rapid metabolizers and slow metabolizers. In an effort to have insurance companies cover the testosterone pellets for those rapid metabolizers at a more frequent dosing than the others. And it was presented as a podium presentation, and I'll be glad to give you the link to that, and that might be something which you might be interested in.
Yeah, that's very interesting. Thank you.
So next, I'm going to ask you about the drug-drug genetic interaction. I think it's a corollary to the same question Dr. Leena Gupta asked. Is there anything else you can shed light on that, the drug-drug genetic interactions?
Well, I think that's kind of what I was just talking about. Yeah, I mean, it's an area that's obviously evolving, and it's an area that is going to make our job in some ways it'll help us, and in some ways it'll make it even more complex. Because if you think you have to look up a lot of things now, looking for what's a P450 interaction, but then adding in the patient's specific polymorphisms and their profile of P450, that's going to make it even more challenging, I think, in some ways.
Awesome. Well, the other question, I think most of the questions are answered. There's one question on gene site testing, how correct it is.
I can't say I have a lot of experience with that. So I'm not sure that I have a good answer. It probably depends on the specific company that's doing it. And, but it's so new in terms of trying to implement this type of thing. I think that maybe some of our hem-onc colleagues might be in a better position to answer this, because I think that they probably do this more than anyone. But in my clinical practice, it has not yet played any role. It's not something that we typically have on our patients in the emergency room.
Okay, great. So I think we have come to the end of the questions. Anybody else who has any questions, please privately, you can put it on the chat box. And Sage and Sari, if you wouldn't mind, just wait after the talk, after the thing is over. And if there are any further questions, you can answer them privately or on the chat box to them. Thank you so much. That was an awesome talk. And before we go to the next stage, and before I ask Anupama to come back in, I would want to give a shout out and absolutely a great AAPI supporter. The CMEs which are coming to you all these years, for the last 2 years, and even more, since Dr. Suresh Reddy's time, has been because of the support and the help of Dr. Vemuri Murthy from Chicago Medical Society. And I will really, I mean, he has given these CMEs to us in such a timely manner. And most importantly, as we, we have to say that we are not the greatest in providing our conflict of interest and all the other CME documentations in time. And he has worked with us through Chicago Medical Society and has given the CME to us for pennies, actually, because and that has helped AAPI, save a lot of money and give you all the CMEs for free. And I want to please have Dr. Murthy come for a couple of minutes and please acknowledge all our gratitude that you have given and shown this AAPI. Can you unmute Dr. Vemuri Murthy? Dr. Murthy, are you still there?
Vijaya, can you add Dr. Murthy to the panel if you can?
Sure.
So thank you so much, Dr. Sogyam and Dr. Wiener. Very good topics actually, and we see them every day coming. Our patients having so many multi-drug therapies, and if I look at each drug, I will take good 10 to 15 minutes just looking at those drugs, what my patients are on. So it'll give so much information like what medication they are on. So I'm sure pharmacy will go through them and check the interactions, and so most of them do well, but it's just the old patients, the geriatric population, who are the ones who are really going into this phase of lethargy or severe bradycardia, or so all those very careful in those geriatric population. Dr. Vemuri Murthy is here. He's anesthesiologist and yeah, can you unmute Dr. Murthy, Vijaya?
I think
is he there?
He's
there, but he's away.
The gallery here, but not.
Okay, he's cannot.
Okay, he's coming. He's coming.
Anyway, our gratitude and our applause, please. We sincerely thank Dr. Murthy for making our job so much easier.
Thank you.
He's joining, Dr. Anupama.
Sure, thank you. We'll wait. And I want to thank Dr. Sagar Galvankar. He is phenomenally exceptional person who brings us the best speakers. We all enjoyed throughout the year, and I should applaud his service to AAPI. It's a purely voluntary service we are all doing for AAPI, this organization of Indian physicians. We have almost about 15,000 members, and we are spread out all over the United States with 130 plus chapters and specialty chapters, local chapters, and we do an annual convention in this year we are doing in San Antonio, and I welcome all of you to attend the convention in San Antonio, June 23rd to 26th. And welcome Dr. Vemuri. Thanks for joining us for this last minute thing. Dr. Vemuri Murthy, he was past president of Chicago Medical Society, and he serves on the education board in the CMS, and he has been very helpful to us to do these CMEs through Chicago Medical Society. I want you to say a few words, and because my term is coming to an end in a couple of months, I'll be finishing this role.
Yeah, thank you very much, Dr. Kutimukula, and thank you, Dr. Ravi Kohli and Dr. Amit Chakravarti. And today we heard phenomenal presentations. I think, the topics, both the speakers have extensively covered the realistic and practical aspects of this very important topic. And, polypharmacology has been there for such a long time. And unfortunately, the amount of the negative impact it does is what we saw today is truly embarrassing to the physicians that keep on prescribing the medications without any scientific evidence or rhyme or reason. AAPI is doing an outstanding job. Congratulations to the CMA director, the president, as well as the president-elect. And we have already instilled the culture of international CME programs, and Chicago Medical Society is extremely pleased to be a partner with AAPI for these programs. And from the bottom of my heart, and on behalf of the Chicago Medical Society, I truly commend your efforts and look forward to similar high quality programs for next many, many years to come. Thank you.
Thank you, Dr. Murthy. And Amit has been very passionate about doing the CMEs. He had past experience as a CME chair, and so he expressed his interest to do the CMEs this year. And thank you, Dr. Chakravarti, for that. And Vijaya, can you get the plaque for our speakers? So this is a small token of appreciation from us, from AAPI. Dr. Wiener, thank you so much for your outstanding contributions in the field of medical toxicology. And we welcome you as a member of AAPI Distinguished Speakers Club. And we look forward for more and more of your talks in future for next incoming years. Thank you so much. And thank you, Dr. Sogian. Thank you for your outstanding talk today on medical toxicology. We learned a lot, and we welcome you as member of the AAPI Distinguished Speakers Club. And we welcome you. Please come to San Antonio. It's my city, and we can host more talks for you here. And thank you so much. And I thank both our moderator and our chair for doing outstanding CMEs every month. And we have excellent topics in the next month as well. And I welcome all the attendees today who have been listening to more than 100 is a good number on a Saturday to attend a CME, sitting there and patiently listening to these two talks. And I thank the audience as well, and hope to see all of you in San Antonio in June. And Amit, do you have anything to say next incoming talks?
Yes. Yes, so thank you so much, and it was an excellent talk this year. As we've kept our promise to make bring interesting topics, which everybody in every specialty will enjoy, rather than being specialty specific. So next time we are in talks to bring one of the greatest talks I think everybody should attend. It's on hospice care. Everybody, for your relatives, for your patients, this is a very difficult task for a physician. We're never trained in this part of the thing. We never know what to do, how to do, and what hospice care involves. People who are oncologists, of course, they are used to it, but all of us have encountered patients who we need to send to hospice. So all the intricacies of hospice care, which is very alien to all of us, or most of us, we'll have excellent faculty. They've not given the confirmation yet, but we are hoping that they will not refuse. We are just waiting for the final confirmation before we send you the flyer. And so next time, our topic most likely will be hospice care. And again, I thank the speakers. They did an excellent job. As usual, Anupama, thank you for giving us the opportunity and weeding out. I just suggest some talks to her, and she picks out one of the best ones. And we have always hit the target every time. Dr. Murthy, thank you again for providing us CME. And last but not the least, Sagar, my co-partner in crime. He and I, get together and we go back and forth in all the options, and finally we come up with the best ones. So thank you again. and hope
Thank
to see
you.
you again second Saturday of each month, same time, May 14th, 12 o'clock Central Time. Thank you.
All right.